we all have to make decisions on our workplaces. If a person is a monitoring and evaluation officer, he or she also has to make decisions, and probably even before the issue comes to the management. So all that we have gone through to this time is important only if we use the information that we received. We have done root cause analysis, identified those causes, and then we have to find solutions. And the solutions, finding the solutions is exactly the decision. Now, to be on the same page, what are underlying principles and what we mean? Decisions are choices made in support of goals. In any case, we have to make decision because we want to achieve something. It is necessary or it is desirable, but still we want to achieve some goals, and that is why we make choice. All decisions are made on the basis of some information. This information may be quantitative or qualitative. They both might come from our monitoring and evaluation component. Decision will be only good if the data that we collected are reliable. It will be good only if we used that information. And here is the first part. The second part is that the decision will be good only if we have selected a decision that we can implement. If we decide to do something for which we have no time, no resources, then it makes no sense to have such a decision. Also, it might sound very good itself. So, and final, but not the least important, people around us have to understand what this decision means and have to agree that this is something to be done. This is a schematic presentation of ideal decision-making process. It was published more than 20 years ago, but still many researchers use this framework because it gives quite clear understanding. It is comprehensive, and it is really ideal decision-making. It has 8 steps. And the first one is already discussed by us. It is definition of the problem. The goal is to express the issue in a clear one-sentence problem statement that describes both the initial conditions and desired conditions. After that, it is necessary to have the requirements, or at least it is beneficial for the process, to have the requirements. These are any conditions that acceptable solution must satisfy. I have some kind of backup, and I don't quite understand why. The sound, yes. So, for instance, if we have a laboratory which has to test at least 10 patients a day, any solution that would lead that the number of patients tested will be less than 10 is not acceptable. So we have to develop this list of requirements beforehand, before any decision. Then we need to define goals. The goals are statements of our intent, so it goes beyond the requirements. Requirements are minimal, and goals are something more, something that we want to achieve. The fourth stage is alternatives. What alternative decisions might be made in order to achieve those goals? The fifth is quite a tricky part. It is development of valuation criteria based on the goals. So how will we evaluate the alternatives to find out, do they comply with the goals or not? These are usually numerical values, objective measures, and they will require quite a bit of work to do in a meaningful way. It should be something that differentiates different alternatives, and it also should be made something important characteristic of the alternative. Then we have to select decision-making tool, evaluate alternatives on the basis of the evaluation criteria that I have mentioned before that, and then after the evaluation process, select preferred alternatives, the solution that should be checked to ensure that it is in line with the goal which we set. So having said so much, let's go back to reality. It was ideal decision-making, which usually nobody does. So from the very beginning, is the problem really problem? So have we done the root cause analysis, or we are looking at the symptom? Most often, the steps 5 to 8 are avoided. There is a matter of timing. I had multiple times situation where something has to be done, and if you ask your superior, when is deadline? When you want me to complete this work? I heard the answer, it was due yesterday. Have you had this experience? Probably yes. It is a sense of urgency. No matter how fast you are, still you should be in a hurry in any case. So this urgency will not allow us to go through all 8 steps of ideal decision-making process. We have to cope with the real situation. Then the question is if there are readily available data. If our decision-making process requires prevalence survey, it is not there, it will not be there. We shall use what data are available through our routine monitoring and evaluation system. This is best approach to follow, especially if something is urgent. And then the last one, who has time to follow up? So we made the decision, we, let's say, asked people to do something, but if we do not follow, it just won't happen. What are purposes of monitoring and evaluation? We have gone through these fundamentals many times during this training, and I want just to pay attention to the last point. It is the purpose of monitoring and evaluation to help inform policy, planning, or program decisions. For instance, new services, resource allocation, corrections, etc. So it is embedded function of monitoring evaluation to help inform some decisions. Otherwise, in itself, it has very limited value. And it is also so important that in recent decade, the new term emerged. This is participatory monitoring and evaluation. And this participatory monitoring and evaluation means that you engage stakeholders, including decision makers, from the very beginning, from the moment when the monitoring and evaluation plan is developed. You can see this. There are numerous articles describing this procedure in healthcare area in various countries. For instance, I have found maternal and child care example, develop this participatory monitoring and evaluation developed in several countries with exactly Johns Hopkins University and USAID support. I would like to present our own example, which was integrated screening for tuberculosis, HIV, and hepatitis C at the primary healthcare level. So it was kind of pilot project in one of the regions which had high prevalence of all 3 diseases. And actually, with our prevalence rates and incidence for tuberculosis and HIV, it makes no sense to have population-wide screening. We do not screen general population. But for hepatitis C, we had prevalence survey in 2015, and it demonstrated that Georgia had one of the highest levels of hepatitis C in the world. So there was a whole strategy, hepatitis C elimination developed with US CDC support, and it warranted screening of general population. The primary healthcare providers were asked to go door to door and to screen population, general population. And if a physician goes door to door, then it makes sense to test not only for hepatitis C, but also for HIV. Then it is cost-effective way to do it because the person is still there. They have to be persuaded to undergo the screening, and just one additional test. Even more simple for TB, because for TB, they were just symptom screen. They were asking questions if they had any symptoms or risk groups, and they referred everybody who would be presumptive TB case. And now we come to the monitoring and evaluation part. As it was a pilot project, we managed to engage local government and local public health authorities. They have created monitoring teams in each district. Each district developed the targets, number of screened people for each month. And they had 6 months period for this. They developed targets and they followed the targets. And because public health authorities and local government were involved, it motivated primary healthcare providers. They felt something they were doing was important. It was for the first time that local authorities paid attention to what primary healthcare physician or nurse was doing. And besides, they were not just checking if the targets are met, they were discussing challenges that primary healthcare providers would face, and there were challenges. And local government representatives helped them, facilitated the process as far as they could to overcome those challenges. I would dare say that the program was very successful. We reached the target for hepatitis C screening, and beyond that, we identified patients with HIV and also TB from those that were referred from this group. And even more that, all the other regions in the country followed the examples from the very next year. They allocated budgets and followed the same route of doing monitoring and evaluation for hepatitis C screening program. Now, what are the reasons to use M&E data and information for decision making? There are numerous, but first of all, this is that monitoring enables us to document positive outcomes and also negatives, what has worked and what has not. So it both helps in decision making. Quite often when we present our programs, we want to stress what worked well, but at the same time, there are things that do not work well. And it is very important to know them and to then not to replicate and replicate only whatever is beneficial for the program. It also helps to save costs. It helps to be confident about our decisions. It helps to prove that our decisions were correct, they are justified, and we can present them to the wider audience. I like that figure very much, actually, this cartoon. Marina also paid attention to that, and I like this one because I had this feeling exactly. I felt like this person with parachute because I used to be a monitoring and evaluation officer myself. So when I once arrived at the National TB Center, it was not even a monitoring visit, formal visit or something like this. We had an indicator that was called interim success rate for DRTB patients. Do you remember that indicator? It was measuring microscopy and culture at months 5 and 6. It was kind of suggested by WHO to anticipate treatment success on time. And it was called interim success rate. This indicator was not routinely collected, and as the outcomes of our DRTB treatment were deteriorating, I decided to collect that information at the facility level. So when I arrived at National TB Center, I asked for patients' charts, more precisely for drugograms, you know, this chart probably where there are outcomes of sputum microscopy and culture. I did not ask for patients' names. I did not ask for physicians' names attributable to those patients. Just I wanted the charts to then cumulatively count number of patients who were on track and were not. Physicians were extremely suspicious of me, what I was doing, why I was looking into patient charts, so that one of them even stood behind my back while I was writing this plus minus from the charts. And really, it took really time before they understood I was not there to check up on them. Because if they do not believe you, you will not have this monitoring. It is not possible. No one will disclose whatever you have to see. And it will not help with decision making, because the strong decisions, they are based on high quality monitoring and evaluation. Marina has stressed this several times that supportive supervision was important, and they become in 3 years accustomed to supportive part of this supervision. But what she did not mention is that she is advocate of those people. She's advocating about all the challenges. For instance, someone decreased the space. These are private providers mostly. They're not that fascinating supporters of the TB program. So it's commercial business, and they have the unit that has limited number of patients, does not generate much income. So from time to time, it happens. The provider decides to decrease the space, or to close the separate entrance, or to move them to another room. So they usually say, Marina, help us. We have these challenges. And Marina goes to the management, calls the ministry, calls NCDC. So they expect not only support with the routine work, but advocacy and support in a broad sense. They now believe that this is somebody who is not their enemy and is rather partner in what they are doing. So it helps with the quality, and that eventually helps with decision making. This is a conceptual framework developed by one of the USAID projects. It pays attention at 4 basic components, which are demand, collection, availability, and utilization of information, which is believed to lead to improved health systems. Let's specify what we mean by the demand. It refers to the value the decision maker places on the data, whether or not they actually use it. So if your decision makers do not believe these data have any value or should be trusted, then they will not assign people to do it, will not allocate budget, etc., and it will not happen by itself. So we definitely need the data to be demanded. And in this case, we will have support from the decision makers. And what is data use? It refers to decision-making process directly. We say that decision maker uses information if he is aware of the decision to be made, considers at least 2 possible courses of action, and considers relevant information in making the decision. It is quite difficult sometimes because some decision makers have no idea of public health. Does it happen in your countries? No? For instance, if you go to Ministry of Finance, they will hardly be interested in healthcare indicators because they don't understand them. There is no demand, and there is no use. Even with the Ministry of Health in Georgia, we have the ministries that covers labor, internally displaced people, health and social affairs. So nobody is aware of all topics. So it is very difficult. We need to find information that will be suitable for these people. If you look at the picture, I think you have seen such thing in your working life, especially in TB program. There is a person covered with these documents, which are paper-based, and this information will stay there if no decision makers use it. We will have that in paper-based forms, and they are not usable. And this is kind of a vicious circle. If we have no demand, we then have no available information. It is not collected correctly and timely, and we cannot utilize it. If you look at this slide, I have listed the barriers to data use, which I found in the literature and also I have experience of, and many of them you have mentioned specifically. And I will just focus on some of them. But first of all, yes, the modern electronic databases, modern health management information systems assist us a lot. They prevent many errors, they are timely, they're case-based, they give us a lot of data and information. But I remember when decades ago, when in the department we had 1 computer, we had training, and the trainers spent a whole day persuading us that electronic systems themselves, they do not solve problems. The problem solving starts from the moment when we decide what we want to monitor. What are our goals? What are indicators that we need to monitor? We should not develop A4 format lists of indicators, because in this case, people are collecting data sent to the supervisors and they do not receive feedback. They have no understanding what this means, and they become demotivated. And this low staff motivation, of course, affects the quality of data they provide. Organizational structures might be challenged because sometimes there is big organization, one department does not know what the other department is doing. Sometimes there is gap in their functions, sometimes there is overlap. So you have different sources of the same information coming from different departments. Lack of data culture among decision makers. Yes, you have mentioned that specifically, and I want to add to that. There is a saying which is attributed to a British Prime Minister of 19th century who said, there are lies, then lies, and there is statistics. So if your decision maker believes that statistics goes after them lies, then it makes no sense to provide this data. We have first to persuade them that this data has certain value. And of course, we mentioned political interference. Yes, if tomorrow there are elections, nobody wants to accept that we have outbreak. There is, yes, and the politicians, they pay attention to that. We have to acknowledge it and to try first to explain what it is, what it means, and then to find ways how to present it. Because for monitoring and evaluation, we talked a lot about different visualization methods, and usually these are charts, graphs, etc. If we look at Georgia's situation, we have Georgian Orthodox Church, which is a very valuable organization, appreciated by the vast majority of the population. So and we engage them into TB prevention activities. But if I go there with the, let's say, scatter diagram, it will be ridiculous. So I have to find other ways to present information in understandable way. Otherwise, it is waste of time. So let's move to the next one. And we have somehow went to the stakeholders. I listed the stakeholders, which we usually have with the TB programs. Can you add someone, or do you agree or not? Okay. So I will just be brief and say the difference why I mentioned those stakeholders. Okay, because they have different interests. Just as a conclusion, they have to make different decisions, so they need different information, and the best way to present this information will be also different. Why I was to skip it, because you will have a separate presentation on that, not to overlap and not to abuse your time. And one thing I also want to mention is that decision-making requires different information, not only for different stakeholders, but at different stages of the program implementation. For instance, when we are starting to develop our, let's say, applications for the Global Fund, at the initial stage, we need to identify the problem and recognize the problem. And for that, decisions are related to priority setting, to advocacy, to target setting. Yes, we'll do this. We identify our problems, set priorities, develop targets, and this is quite a communication with the local stakeholders and the Global Fund. And type of data and these decisions will vary in accordance with the phase of our project implementation. And the final stage will be evaluation, as it is anticipated. So these are, I will not go into detail due to save the time. These are different data and information sources which we all use probably. So it's census data, vital events, surveillance, household surveys. Do you may have household surveys? Do you use it? For TB, I mean.
Don't have money.
Yeah, this is really expensive, and but we also did not have TB data in household surveys, but we used the opportunity to add a couple of questions related to TB. It did not make it more expensive, but still it was useful because this is related to household payments for expenditure for TB. There are several tools And I will just say that all these tools have quite similar purpose to help systematically align decisions with appropriate data sources to help identify, prioritize key decisions and information needed. We actually are doing this, I believe, all the time, but there are several tools that will make it easier because they are flexible. They do not require much time. For instance, this is a sample of tool which will group into 3 categories: policy planning, program design, and program management. It will help us to identify how often, what type of information, what are next steps, what should be done, and what is timeline. So it is time-bound plan that might be helpful for us to have a systematic view on the data requirements and assist with decision-making. The next one is assessment of data use constraints. We have talked about the data use constraints right now, but there is, again, a special tool that would help us with this. This is more based on stakeholders. There are several questions. It is just part of the tool. You select key informants and ask those questions, and this will help us to identify real barriers, which is not just our assumption, but also the opportunity to engage those key informants to get additional information and, in best case, to possibly find solutions to these barriers. So the next one is stakeholder engagement tool, which again, I will omit. Now, information use mapping, this is the first one which I wanted to present. It is the way to graphically describe the information system or subsystem. I liked it most of all, actually, because it shows flow of information. So we can see who collects the data, what exactly data, where the information is stored, who is doing analysis, who is doing reporting. Then if we have some challenges with this information, it will be easy to identify at what level this information has been maybe collected in a wrong way, or analyzed in a wrong way, or reported in a wrong way. So it is easier to correct than what was missing. And finally, the framework for linking this data with decision. Again, it is one of the tools. All these tools are quite flexible. We can use them in a way that we like, that is more appropriate to our environment. And all of them have the common that they encourage greater and better use of data and information in decision making. So again, we list the stakeholders. We list the decisions. I have filled in just one of them for the example. So there is timing, there is reporting frequency, there are indicators, source of data. So it will help us to identify if we have gaps, then where do we need the corrective actions. So in summary, and I am on time. You can congratulate me, because so we say that decisions based on evidence lead to better health outcomes. High quality information is needed for decision making. The purpose of monitoring and evaluation is not just to produce more information, but to use that information and improve our performance. And I hope that you agree with me on that conclusion. Thank you.